All right, we're all set.
Yes. Hello, everybody. Welcome to the GHI Wiki Partnership for Excellence in HIV Care across Central Maryland, our webinar toolkit series. And it's really exciting and my pleasure to be here today with one of our own, near and dear to my heart. So first, a little bit about partnership. It is a multi-partnership partner venture with the goal and vision to achieve a more coordinated response to HIV care by establishing mutually beneficial relationships that increase the quality of care that we provide as a community. Our target population really is women, infant, children, and youth, or the WICI population as you hear it. And our mission really is to work with all of you to build upon the existing structures and systems that exist for all of us, and to create a dedicated network of providers to coordinate across multidisciplinary systems of care. So the goal here is to engage and amplify. So you're engaged if you're on, and amplify not just what we do, but what you do as well, so we can learn from each other and increase the ask in terms of up in the ante of care for our populations. Next slide, Marinas. So this is our virtual webinar series, and today, hopefully this is not the first one that you've attended. We've had several rapid start with Joyce Jones, a great one on dealing with provider burnout. And today, my pleasure to introduce David Griffith, who will be talking about transitioning to adult care and how to ensure effective transition from adolescence to adult. We have several subsequent ones coming up here in terms of optimizing quality improvement initiatives, Gender Matters, Women-Specific Care with Jean Keller, and then Renata Arrington Sanders on HIV and PrEP. Really excited for those, so hopefully you can join us. Next slide. But to introduce first David Griffith, and for many of you, David does not need an introduction. He's an assistant professor at the Johns Hopkins School of Medicine. He attended school close by the University of Maryland, completed a Med-Peds residency at the University of Rochester. He then completed a combined adult and pediatric ID fellowship here at Hopkins, and is currently the medical director of the Johns Hopkins HIV/AIDS program, which provides HIV care in partnership with health departments across the state of Maryland. He also practiced at Johns Hopkins Hospital in both peds and adult HIV clinics, as well as general pediatric infectious diseases primarily. He has a clinical and research interest in prevention and treatment of HIV in young adults, and does bridge the divide in terms of providing care on both the peds and adult sides and as part of the transition team. With no further ado, really, it's my pleasure to introduce my friend, colleague, and mentee, David Griffith. Take it away, David.
Thank you. Let me share my screen here. And presentation mode. And all right, are you guys seeing presenter mode or just the slides?
We're seeing presenter mode, David.
All right.
So we see your next slide.
How's that?
Perfect.
All right. So give me one sec. All right, so it's a pleasure to be here with everybody. Thank you for the invitation. I am excited to talk to everyone about transition.
David, this went back to your, just so you know, that's Infectious. It's more in the slide view for individuals and not presenter mode.
Sorry. Here I thought I was going to be nice and smooth.
There you go.
Let me bear with me one second, okay?
That was perfect. You're actually perfect.
Still now?
Yep, we see now objectives. You're all good.
All right, great. Sorry, I'm not seeing it, so let me just.
David, if you click on the green tab right above your presentation, it says view options. You may be able to change it there so that you can see your presenter view, but then we will only see your slides. And it's right at the top of the screen that you're sharing. At the top, it says you're viewing David Griffith's screen, and then it says view options. And at that section, you should be able to change your settings.
All right, what I'm trying to do is have a Word document open at the same time, and that's where I'm
okay.
thrown off here. So I apologize.
It's okay, you're just building up the anticipation.
Doesn't help that I have like documents open on my computer. All right. Now what are you all seeing?
Slide view, not the presenter mode.
All right, and now you guys are good here, right?
No, we're seeing, it's presenter mode, but it's
Right there in presenter mode, if you clicked on the options on the top of the screen, you would have been able to.
Yeah, see, I'm not, there we go, here we go. This
Perfect.
is what you do?
You have to
swap?
swap it.
Okay.
There you go.
I
Perfect.
truly apologize. Now still good?
Yep, we're all good.
we're working.
All right.
Don't worry, let's go.
Thank you, everybody, for bearing with me and my confidence. So I'm going to talk today about transition of youth to adult care, and I'll be sharing mostly my experience as a provider who works in both the pediatric and the adult HIV clinics here at Johns Hopkins. All right, so our objectives today are to review the epidemiology of youth living with HIV, to discuss these challenges of transitioning youth living with HIV to adult care, and outline strategies for effective, successful transition. So what is transition? What do we mean when we talk about transition? So transition is defined as the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from a child-oriented to adult-oriented healthcare systems. When we talk about transition for youth living with HIV, we're generally speaking about the transition from a pediatric HIV clinic environment to an adult HIV clinic environment. In the United States, this generally happens around the age of 25 years. However, it can happen earlier depending on individual patient needs. So transition in care for youth living with HIV is important. And why is it important to talk about? Well, firstly, in the area of highly effective antiretroviral therapy, youth living with HIV are aging into adulthood, and it's inevitable that they will eventually transition to adult care, as most pediatric clinics are not set up to provide care for adults. Secondly, it's important to talk about transition because transitioning to adult care can be very challenging, and it comes at a very challenging time for youth living with HIV. And it can potentially lead to disengagement from care and therefore potential worse health outcomes when transition is not successful. So I'm going to focus firstly on the first point and talk about the epidemiology of youth living with HIV and how that relates to the transition process. So this slide represents the age distribution of persons living with HIV diagnosed perinatally from 2017. Unfortunately, it wasn't able to find any newer CDC data. This graph shows that a large proportion of perinatally acquired individuals have already entered adult care as they're greater than 25 years of age. But we can also see that there is the largest proportion are still in that 13 to 24 year age range and are nearing transition. And given that the slide is out of date, many of them have probably already transitioned beyond age 25. And as that group moves forward, we need to continue to prepare for them and allow them to have a smooth transition to adult care. There have been dramatic advances in the prevention of mother-to-child transmission of HIV over the past 2.5 decades. However, despite these efforts, there continue to be new diagnoses of HIV among children. So this graph shows the number of children less than 13 who were diagnosed with HIV from the years 2014 to 2018.
Hi, David. We're having a lot of issues hearing you, and I'm seeing that other people in the chat room are saying they're having the same issues. I was wondering if maybe we can move the computer around a little bit or try to do something to improve it.
Yeah, the sound was just going in and out.
Okay. Okay. Yeah, I'm in my office, so I don't know what the internet situation is here. Can you hear me now better?
Yes, I hear you a little better now. Let's just
I'll lean
keep
in.
going and I'll let you know if we can't.
All right. Yeah, please interrupt me if people can't hear me. So I was just saying that though we have dramatically decreased the number of children born with HIV in the United States, the number has not gone to zero. And as you can see in this graph, there continue to be children born with HIV in the US. And in addition to children born in the US, we do have patients entering care in the US who were born in other countries, either through international adoption or immigration to the United States. So the number of children with HIV, though decrease, persists, and we need to make sure that these children, as they age, have a smooth transition process ahead of them. In addition to youth with perinatally acquired HIV, our pediatric clinics also care for children with non-perinatal HIV. So this graph shows the new diagnoses of HIV among adults and adolescents from 2014 to 2018. And you can see the purple line represents 13 to 24-year-olds and the rate of HIV diagnosis in that age group. And though it shows a slight decline, I would argue that for the most part over these past 5 years, that rate of diagnosis has been rather consistent. And many of these 13 to 24-year-olds are entering care in pediatric clinics. And so we have to make sure that as they age, they're also transitioned to adult care smoothly. And though there are many differences between youth with perinatal HIV and non-perinatal HIV, both groups face similar challenges when it comes to transitioning to adult care. As I talk about the challenges facing youth who are transitioning to adult care, it's important to talk about the challenges that youth living with HIV face in general. So this is the care continuum for youth living with, presenter mode.
Yeah, you're in the right mode.
Okay. All right, so this is the, does my screen sharing keep closing?
Yes.
It's not, I'm not doing that.
Not sure.
On its own, unless someone else is, but probably not. I'm sorry, everybody.
It's okay. Marinas, do you want to try sharing your slides? Maybe it's more central. Maybe it's David's computer. Maybe you try saving and then advance for.
I can also try to make him the host of the meeting. I think that'd be a little quicker.
Okay. Okay.
I do that now.
Sure.
Okay, David, now you're the host.
All right, thanks. All right, how's it look?
Perfect.
All right. So we've talked a little bit in this series about the challenges facing youth living with HIV. So this is a care continuum graph from the CDC. And it shows that compared to adults living with HIV, youth have poor outcomes at every stage of the continuum. So in purple, you can see out of 100 youth between the ages of 13 and 24, only 55 have received their HIV diagnosis. And of those 55, in blue, you see only 43 have received some HIV care. And then in red and yellow, you can see that only 32 and 33 respectively have been retained in care and are virally suppressed. And you compare that to the adult numbers, whereas 86 have received their diagnosis, 65 have received care, and 50 and 56 are retained in care and virally suppressed. So it's clear that youth are more challenged along the care continuum. And why is that? So youth have many barriers to care, and many of them are psychosocial, logistical, or medical. From a psychosocial standpoint, you have a poor risk perception, and a lot of that has to do with their stage of development through adolescence. There's also a lot of logistical challenges for youth, the limited health literacy, and competing priorities such as education, employment, or childcare. And then additionally, medical challenges, mental health, substance abuse. And then within all of that, you have the context of social determinants of health, such as race and poverty, which overlie everything and contribute to the challenges our young people face. So I'd like to highlight some of the challenges in transition with a case. So this is a 27-year-old woman who had perinatally acquired HIV. And she presented to a health department clinic where I see patients. And she'd been out of care for over a year, almost 2 years, where she hadn't seen a provider and had been off medication. She previously had gotten care in the pediatric HIV clinic until the age of 25. And then she transitioned to the adult clinic. She had an initial nursing intake at the adult clinic and then never went back. She did not like the adult clinic environment, did not want to be a patient in that clinic, and then was lost to care after that, never made her first provider appointment. At the time that she was transitioning from the pediatric to the adult clinic, her viral load was undetectable and her CD4 count was greater than 200. However, after being out of care for almost 2 years and representing when she was 27, her CD4 count had declined to less than 50. She remained in care at the health department, but was not able to successfully restart her antiretroviral therapy for almost another year. Ultimately, she transitioned from the health department clinic to our Johns Hopkins clinic, where I had more scheduling flexibility and there were more support systems in place for her. And happy to report that she's now been on antiretroviral therapy for a whole year and now has an undetectable viral load. So this case really highlights the challenges in transition, that the pediatric clinic is a very distinct environment compared to the adult clinic. And our patients aren't always prepared for that transition. Additionally, during that transition period, patients need to continue to be followed to ensure that if they miss their visit, they can get rescheduled. We can kind of reach out and triage and try to figure out what the barriers are. But this is an example where that process failed, but thankfully she re-entered care and was able to get healthy. So that case highlights some of the transitions. So let's talk about a few more of them. So one of the biggest challenges is the end of some very long-term relationships between the patient and the pediatric clinic staff. For youth born with HIV, many have spent their entire lives in care of the pediatric team. And so they can experience a real sense of loss as they think about moving on from that clinic to another space.
Excuse me, David.
Yeah.
We're having sound issues again.
All right, I'll get closer.
Okay, thank you.
Additionally, so those long-term bonds with pediatric perinatally infected youth are very strong, and the loss of those bonds can really be felt by them as they transition. And though youth with non-perinatally acquired HIV have been in clinic typically a shorter period of time, they still have formed strong bonds because that pediatric clinic staff was the team that supported them through the initial diagnosis and getting them on therapy, and can have that same sense of loss as they move on from that team. This transition period is very high risk for disengagement. As patients leave pediatric to adult care, there is an increased need for autonomy. We try to ease that transition, but inevitably the care that patients get in a pediatric clinic, there are going to be many things that they'll need to do for themselves on the adult side that maybe they had help with on the pediatric side. And that can be cause a lot of fear and anxiety for the youth as they transition and enter a new clinic where there are new systems and protocols. And the environment is very unfamiliar. I know that personally, when I'm in the adult clinic, it's a bigger space. There are multiple stations and units within the clinic. I often have trouble knowing kind of some of the logistical processes in the adult clinic. And I know that patients also feel that. So I relate to that. The pediatric clinic that we use is a much smaller environment and easier to navigate for our youth. So if things come up with their health insurance, for example, they may not know who to talk to. And as a result, miss medicines, fall out of care. So it's important that we understand that challenge for our youth. Studies on retention after transition to adult care are very challenging because there's so many different clinical environments. The studies that have been done shown between 50 to 80% retention in adult care after transition to adult care. There are clinics that have a co-located pediatric and adult clinic. And so you can imagine that's a much easier transition because the physical location hasn't changed. In clinics such as ours, where the patient must transition to an entirely new space, there's a higher risk of retention issues because of the logistics involved there. So those clinics may see a lower retention rate compared to the clinics with a more simple transition structure. I wanted to share this quote. It's from a paper that looked at patient perspectives before and after transition. And this is the perspective of a patient in a pediatric clinic as they anticipate transitioning to the adult clinic. So it starts out the social service provider's name. She'll just reach out. Hey, how are you doing? Just making sure I'm good. Just, are you having any problems? Is everything okay? Have you been able to book your appointment? If I miss my appointment, I can email her and say, I missed my appointment. Can you help? Oh, let me help you out. That's why I love the pediatric. That's why I don't want to leave. So this just highlights some of the fears that patients have. They know how to operate within a pediatric clinic structure. And there's potentially a fear that when they go to the adult clinic, they may not know how to operate, or even worse, they may not even have a realization that the adult clinic will be different. They may expect the same level of connection and ease on the adult side. And when that's not there, can have real trouble rebooking their appointments or getting their medications because they just don't know how to do that because it's just a more complicated structure. It can be very, very overwhelming if youth are not prepared. So it's very important to have a clear plan. We talked about the challenges that transition can face. So what do we do about it? I find this very helpful. And in 2013, the AAP released recommendations for pediatric clinics working with youth living with HIV to facilitate a comprehensive approach to transition. It's a very simple approach, but I think can provide a lot of success. So firstly, it stresses the development of written policies to guide transition. It's important that we're not reinventing the wheel every time one of the youth transition to the adult side. This can also help standardize protocols, which decrease the risk of things falling through the cracks. It can also help when new staff come into the clinic to have a framework for youth. It's also, secondly, important to create a transition plan with the youth, their family, and providers together. And this is something I personally find challenging. I know when I'm in a visit in a pediatric clinic, I'm also often focused on that immediate need that's in front of me. And many of our youth have challenges that kind of take that priority, and those are immediate challenges. It can be hard to pause and do the long-term planning during very busy visits. And so it's important to kind of mark out time to actually pause and prepare the family and youth for that transition process. There must be a planned facilitation of the youth's connection to the adult clinics as transition is initiated. So eliminating some of that mystery of the adult clinic. Ideally, young people can meet some of the team from the adult side before transition, either the provider or a nurse, case manager, or social worker, so that some of those questions about who do I call when I go to the adult side when I have a problem, some of those are eliminated, and some of the fear will be eliminated because you actually can put a face to that clinic space. And then finally, communication between adolescent and adult clinics during the transition process is essential. So that the case that I highlighted, the young person didn't have a strong connection to the adult side, but there was no communication between the two clinics to help facilitate her successful transition. So really, it takes a communication back and forth. Talk about another case. Oftentimes we talk about the challenges of transition, but there are many youth who transition very smoothly. They're doing well in pediatric care and they do well in adult care. And so it's important to highlight that many of our young people do great. And there are also young people who kind of weren't doing good in pediatric care and ultimately when they transition to adult care do better. So this is a case where I want to highlight that. So this is a 26-year-old patient that I see who newly transitioned to adult care. He'd been diagnosed at the age of 18, entered care in the pediatric clinic at that time, was started on ART at that time, but despite treatment and engagement in care for 8 years, never achieved viral suppression. Though he often would be off and on meds, he didn't have any sustained periods where he was taking his medication. So he, because of his age, he transitioned to the adult clinic and did well in terms of engagement after transition. But in the first few months, he voiced frustration with the lack of support compared to the pediatric clinic. Where he could, he felt like there were people who could really help him take his medicines in the pediatric clinic and didn't feel that same sense in the adult clinic. And through lots of different trial and error, we tried different things in the adult clinic, but ultimately he still had difficulty with his medications. At the time of transition, his viral load was 1.2 million and his CD4 count was 40. So he had advanced disease. However, after about 3 months in the adult clinic, he started taking his medicines. He's now has sustained daily ART adherence for several months. And this is the most consistent he's taking his medicines since his HIV diagnosis. So a lot of times a new environment can potentially be helpful for our young people, just a change of scene, a change of perspective. And also maybe it has nothing to do with either clinic. It's just for this patient on his journey, now is the time when he was able to commit to taking his medicines. And I think it's important to highlight that you can have success on the adult side, even if you haven't on the ped side. And I'll talk a little about specifically what we do at Johns Hopkins for our youth transitioning to adult care or youth who are diagnosed and entering adult care. So,
Hey, David.
Yes.
Sorry to bother you again. The sound is still going in and out a little bit. Can we try turning off the camera and seeing if maybe that improves the sound?
Sure.
Thank you.
Can you hear me now?
Yes, we can.
All right. So our Johns Hopkins, within our Johns Hopkins Bartlett specialty practice, we have the Access Care Early Youth Clinic. So this is a clinic for both perinatally and non-perinatally HIV infected youth between the ages of 18 and 30. So this clinic is designed for youth transferring from pediatric care or newly entering adult care if they have issues that may be a barrier to adherence, such as mental illness or substance abuse, or if they've shown adherence issues in the past. And the goal of this clinic is to be housed within the adult clinic, but provide a comprehensive youth-friendly integrated team approach to HIV care. So this highlights the different ways patients enter the ACE clinic. Either they transfer from our pediatric IPC, pediatric adolescent HIV AIDS program. New patients can enter, or patients can transfer within the adult clinic. The ACE team is made up of medical providers, physicians, and nurse practitioners. Several of our medical providers see patients in both the pediatric and adult clinics. Me, Dr. Agu, and Dr. Sanders all see patients on both clinics. We have a dedicated social worker for the ACE patients. We have a dedicated nurse case manager and a dedicated patient navigator. We also have the benefit of some mental health providers who see patients in both the pediatric and adult clinics and can bridge that gap. Specifically about transitioning from pediatric care to the ACE clinic, we have coordinated transition between the pediatric adolescent HIV program and the ACE clinic. As I mentioned, several of our ACE providers see patients in the pediatric clinic as well. So this provides really nice continuity. Though the clinical space changes, the case management changes, the provider stays the same for our patients. For patients in the pediatric clinic who have a provider that only sees pediatric patients, we'll often, we routinely have one of the adult providers see the patient in one of their last visits in the pediatric clinic, so that when they go to the adult clinic, they have already seen their provider on the pediatric side. So either me, Dr. Agu, or Dr. Arrington Sanders will do that last visit to provide a bridge to the adult side. The ACE clinic patient navigator and the pediatric nurse case manager work to orient and escort patients to the adult clinic. So as much as is possible, either the patient navigator from the adult side coming to the pediatric side to meet the patient and walk them over to the adult clinic and orient them, or vice versa, having the pediatric team walk the patient over to the adult side and kind of do a warm handoff between the two teams. We have regularly scheduled meetings between the two teams to review upcoming patients who may require transitions and the issues that may be encountered there. We have a weekly call for our ACE clinic patients, and our pediatrics clinical social worker regularly joins that call. And what's nice is many of our patients are able to maintain the link to the pediatric clinic through the transition process. So patients who don't know who to call on the adult side to get what they need can still contact the pediatric clinic, who then facilitate that on the adult side. So keeping that connection alive has been very helpful. One of the projects I did as a fellow was to help understand the outcomes of this youth-focused clinic. So I compared 2 years of data for the ACE clinic, and I compared that to a kind of a standard of care in the adult clinic, so patients who were not getting that enhanced youth-focused services. So by design, ACE patients were more likely to have substance abuse and mental health diagnoses, but were also found to have lower education attainment, higher rates of unemployment, and higher rates of incarceration. In the analysis, we found that ACE patients had less loss to follow-up compared to the standard of care in the adult clinic and had better retention in care, 49 versus 26%. When we look at within this patient population, the retention of patients transition from pediatrics to adult care, 76% of those with perinatal HIV and 76% of those with non-perinatal HIV were retained in care on the adult side. So good rates, but not perfect. So even despite all of our youth-focused care, there are many patients who still are not being retained. It doesn't mean that they're not in care or not taking medicine. They're just not quite meeting our metric of a visit every 6 months. And I would argue that since this study, we've kind of streamlined and improved a lot of our processes. And I expect we to revisit the data, those numbers would be much higher. In the study, we found that social work and nursing interactions increased likelihood of retention, just showing the importance of a multidisciplinary team, and that personal reminders from an outreach worker decreased likelihood of missed visits. So our patient navigator on the adult side really playing an essential role to keeping that communication open for patients and reaching out to them if they are having issues, as many of our transitioning patients do. So to kind of summarize, the take-home messages I have for transitioning patients to adult care is that successful transition really requires planning and a multidisciplinary approach. So using social workers, navigators, nurse case managers, and physicians to really make a plan together for each patient and meet patients where they are and address the unique needs and challenges of patients. Every patient is going to have their own concerns and issues, and a standard protocol will not work for everybody. But having that youth targeted approach on the adult side really does ease the transition process, and kind of understanding the environment of the pediatric clinic and how we can replicate the best aspects of that on the adult side is really important. Good communication between the two teams and the patient is essential. And finally, patience and consistency is key. Not every patient will transition smoothly, but that's okay. As long as we continue to reach out and be available for them, many patients find their way as best they can, and we just need to support that and be available for them through that process. So that is all I have. I can take some questions. I apologize for the audio issues and the technical issues along the way.
No worries. Thank you so much, David. I think certainly near and dear to my heart and our heart. Are there any specific questions for David? I have a few, but want to open it up for individuals who may have questions.
I did have one question.
Sure, go ahead.
So there was a slide earlier that showed new infection rates between adolescents ages 13 through 25. Is there a further breakdown of that age range? Because there's a big difference between a 13-year-old and a 25-year-old. So I would have different questions for, you know, someone who's like 13, 16, 17, or like 24, 25, who's newly infected, just based on their ages.
No, you're right. To break down the data in more detail, they tend to group like 13 to 19 or 13 to 18 and then 19 to 24. And the vast majority of that 13 to 24 age range are in that second group, the kind of 19 to 24-year-olds. I would say, I don't remember offhand, but probably 80% of those diagnoses are in the kind of 20 to 24-year-old range. But we do have patients younger than 18 entering our clinic, a few every year. But you're right, the numbers are fewer.
question. Other questions for David? David, I have one. I think Brittany's question is one that we oftentimes get in terms of really the cognitive sort of developmental approach that may be different between 13, 15-year-old versus a 20. So I think that that's important. One question I have for you, and I think I know the answer, but I'll ask you anyway. What do you think is the magic, right? So you described patients, the diversity of patients, but particularly that one patient who wasn't doing well and then changed. What do you think when you've seen that happen? What do you think it is that helps that, I guess, that light bulb come on for patients, and how do we facilitate that light bulb?
I think that one thing I don't think about that particular patient, it's just a lot of availability for the team and the patient. So listening to their concerns and just continuing to readdress those concerns, and a lot of it is just kind of being there, I think helps, though we may not be solving their individual concerns and issues. I think that the consistency that we show, and it allows us to continue to reinforce messages. So they may have a specific concern that's an acute issue, but taking advantage of that and then reiterate the kind of need for the long-term med adherence. So it's taking every opportunity, every interaction to kind of reinforce those things and just be patient. I think that interestingly, telemedicine has been helpful for a lot of my patients. Both these patients, though I didn't include it, did well in COVID. And I know with the first patient I talked about was out of work for about 3 months. And that was a time when she focused on medicines, where her work schedule had always kind of been her priority. And so something about having that period to get over the hump and start taking meds was important. And maybe that goes to some of the competing priorities and just the general stress of our young people's lives, and removing as many of those barriers, I think can help them refocus on their medication. So I think telemedicine could be something we do more of, because it allows us to provide potentially more support for our patients when they can't physically be here, but still need us.
There are a couple of comments and a few questions in the chat. One, just commenting on young people being savvy with technology, sort of referring to how they've done better with some have done better with telemedicine. And then a question from Siobhan Solano about how long are the new patient and return visits, speaking to the amount of time it may take to do some of what you're talking about. Could you speak to that?
Yeah, I spend, I feel like I spend a lot of out of visit time interacting with patients. And that is a challenge. I think I generally will spend 30 to 40 minutes with patients in a visit. In a busy day, that's not possible, but my schedule usually has some no-shows, or with the COVID schedule, I'm able to do that. But I think that's a great point. We don't always have the time, and it requires phone calls on non-clinic days to patients and a lot of care coordination. And that's a challenge for me, because it's one, you feel like you without that, you worry about patients falling through the cracks, and so you want to maintain that, but it can be difficult to sustain that level of engagement, which is why you have a multidisciplinary team, but it is time consuming. I don't know, Allison, maybe you have additional.
No. I was just going to say the official is 30 minutes for follow-ups and an hour for new patients. We do take advantage, and there's been a lot of tweaking of the model for, there's a nurse visit that happens before where there's an intake. And so we have a multidisciplinary ACE discussion. So the nurse and the outreach specialist, Erin Powell, meet with the patient ahead of time. We get a good sense of what's happening. And so you go into that first appointment a little bit more armed with data. but it's used an hour and then a half hour. And really, once you get over the hump, because there's a hump for patients, I think, and then some of the intense interaction may not need to be, and you definitely rely on multiple to do that. So, Brittany's asking, could you speak more about helping with the transition from the Harriet Lane and Bartlett, and who's involved, et cetera?
Yeah, so Allison, maybe I think COVID kind of got in the way of some of our regularly scheduled transition meetings, but there's in the past, the patient navigator and nurse case manager from the adult side would meet regularly with the pediatric nurse case manager and pediatric social worker to review those patients. And so I think that is a good part of the system, but the fact that you, Brittany, don't know about that is a good example of how we can maybe continue to work on this process and try to formalize it. Because your role as a social worker on the adult side for our ACE patients is an important one. But I do think that COVID has gotten in the way of some of that, our more regularly visited conversations.
Yeah, so I think that's speaking to the Bridging the Divide transition team meeting, that there were some lapses during COVID, as there for everything, but that has been restarted, and basically there's a list of patients that are coming to transition, and then a feedback loop with the ones that have transitioned to make sure that they haven't been lost. And so those were reinstituted. But you're right, COVID paused a lot of things because we all tried to swim. Let's see, there's another question about the social worker nursing do any coaching? And, I there are a few social workers on the call. I would say yes, and I think we're all doing some, as motivational interviewing, which was one of the earlier webinar topics, and, MI and other strategies. But, maybe Brittany, you can speak to this in terms of the social workers and the team members using as much as possible to empower the kids and not just have the team do everything. That's not the goal. Curious, maybe Brittany, you can speak to that, empowering young people to get them ready for transition and engagement.
Well, I usually interact with the patients after they have already transitioned to the ACE clinic, but I do my best to do empowerment and coaching, but also being very supportive. I understand that transitioning from pediatrics, where there's a bit more hands-on assistance, to an adult clinic, they're not quite ready to just be like, okay, these are the places you have to call. This is what you have to do. Go off and do it and check back in with me. So it's also seeing where they are in the process and the amount of, I don't want to say hand-holding because that's so infantilizing, but the amount of assistance that they might need from me while they're getting used to the clinic and used to having less involvement from the care team.
Yeah, I think really important. I think the recognizing that while we're talking about the transfer, the official transfer from peds to adult care, the process of transition actually starts really from way early in pediatric care, 10, 11 years of age, where you're prepping young people for that transition, for the perinatal ones and the ones that are diagnosed later on in life, always preparing and empowering and teaching. It's always happening. So it's not a shock, but they're also the skills, the life skills that help them to do other things, like to register for school, et cetera, are the same things that may help them do better in transition. So it's a long process. And I think sometimes we think about it as it's starting just in the year before they go, but it's really a multidisciplinary, multi-year process that is revisited constantly. And so the better we do that on the ped side and empower them on the ped side, the better they may do on the adult side. I love how you mentioned, Dave, that there's some individuals that don't need all that support and just are ready to go to the adult side and do better, and vice versa. And so I think it really is truly meeting the patients where they are, and it's almost an individualized process, setting up the infrastructure so you have the communication happening, but settling that within that one person and figuring out with this person, how do we individualize that process for them to then optimize the likelihood that they're going to have an outcome. Let's see, there is comments on your talk and highlighting the patient's inconsistency and knowing that sometimes they're not hearing that today, but revisiting it again and again, and eventually they may get it, and sometimes they won't. I think is really important. So definitely a lesson in labor of love. Other questions or comments for David?
Sounds like a no. Thank you everyone for listening. And I think that a lot of the success of our patients has to do with everyone here on this, a lot of the folks on this call who do a lot of the legwork to help our youth.
Right, absolutely. I'll say it's really appreciate the attending. And while we highlighted our program here as just an example of what transition looks like, recognize that they're transitioning happening all over the city, et cetera. So we're happy to be a resource, but also just wanted to highlight that these are youth that are at a crossroads often. And if we are not thinking about it, there's a possibility they'll fall out of care, et cetera. And so really trying to make sure that we're all thinking about young people, at those crossroads to make sure that we don't end up losing them. And so happy to weigh in, to provide feedback, but really do appreciate, again, learning from you and hopefully vice versa. And with that, we'll stop and remind you that next month it's Gender Matters with Jean Keller. Really excited to hear about that and the special population of women living with HIV and some of the programs, initiatives, and the needs for that population. Great job, David. Thank you. And thank you everybody for your attention. Please do fill out the survey and give us feedback when you get it. Marina, do you want to give them a sense of when they should get that and et cetera?
It usually takes about a week to get the survey out and to get the recordings.
And if you're sitting here and you say, wow, I have this really great thing I want to talk about, or our program is doing something really great, please do let us know in that survey, because again, it's to engage and amplify. We want to amplify your voice in what you're doing as well, to really, again, increase how we take care of the populations across the region. All right, thank you so much. Have a great weekend, have a great holiday weekend. Is it a holiday weekend? Are we there yet? Not yet.
Not yet, almost.
Almost.
You're dreaming.
Take care, everybody. Thank you.
Bye, everyone.
Bye-bye.